There is improvement in the adult mental health measures, with now only the care and treatment plan standard in this report not meeting the targets. And again, we've previously reported some of the fragility and variability in that for us, given the small nature of our teams. For children and young people's neurodevelopmental services, we continue to improve against the 104-week standard that the board agreed, noting that the Cabinet Secretary's direction for this year is to meet a 3-year standard, and therefore we are well within that, but also noting that the actual target in the NHS Wales Performance Framework is 26 weeks. And we will be mapping our trajectory in that service for discussion with the board in February as part of the assessment against the annual plan. However, so we have been reporting that we had a blip in referrals, a bulge in referrals in July, and that's largely smoothed out within the service now, with only one over that 104-week standard in November. So on commissioned services, Swansea Bay and Howth are meeting the planned care target for our population, whilst other health boards are not, in line with the Cabinet Secretary's priorities and the investment and the work of the health boards and their teams. The health boards are all improving in that space across the piece. And we would expect intuitively to see a further drive towards improvement up until the end of March, given that being a high priority within NHS Wales. In line with our commission intentions for this year, there's evidence of slowdown in activity in Wye Valley and Robert Jones and Agnes Trent, however, not in Shrewsbury and Telford hospitals, and we remain in dispute with that organisation, without being escalated to Welsh Government around that issue. We are very concerned about the deterioration in the long waiting performance in Robert Jones and Agnes Trent, which is unrelated to our commissioning intentions and is around their demand and capacity issues, some of which are to do with complex spines, but across other orthopaedic specialties as well. We have escalated to them, and we have asked for a recovery plan. The first cut of the recovery plan didn't meet our needs, and we are continuing to escalate that matter to scrutinise and ask for further assurance on that. We have also raised that with Welsh Government and continue to do so through our performance meetings with them. The pattern of performance remains the same in commission providers for cancer, urgent emergency care and ambulance services, with continuing concern about the purple response median times for our population, largely due to the rurality of our geography, but we continue to raise that through the Joint Commissioning Committee arrangements. There has been an amendment and an update in Q3 on the enabling actions. So the board will now note that the text of the report doesn't quite reflect the table that is beneath it. So the text of the report says there's nothing off track, but as is reported in the table, there are actually 3 areas off track, which is the executive committee we have reported, looked at, and we have reported that through to board and also to Welsh Government in their reporting. So there are 3 red areas in enabling actions for us, being achieving 7 cataracts on a list, achieving 85% theatre efficiency, and eradicating healthcare support worker agency. We continue to work on all of those things, and we monitor and report on that fairly to Welsh Government. Some of those are due to our pattern of service, with reliance on commissioned providers, and our pattern of service delivery in terms of our hospital sites dispersed across the county. However, we're not complacent on any of those, and they will feature further in the annual plan for next year. We also wrap into this report now our reporting on the Quality and Outcomes Framework, which is a national framework. And again, because of our unique pattern of employment and service delivery, there are some measures there which, again, we continue to keep under greater scrutiny as an executive team. But because of our unique nature, that we don't benchmark as well as we would like on those at the moment, and those are explained in the report. So that's what I wanted to say in introduction, Chair. So happy to hand back to yourself.
Thank you, Nicola. Really helpful. Again, a very accessible report and very clearly articulated presentation highlighting the areas of importance. So thank you very much for that. Just before I invite colleagues to come in, Nick, I just want to pick up the observation we had from Llais earlier in relation to this report, and their observation that the emergency care statistics may be a little affected because people are choosing to drive rather than wait for an ambulance and so on. I just wondered whether you had any comment or observation in response to that.
Very useful to have that feedback from Llais, because obviously they'll be getting that directly from patients and people that are accessing those services. We'll take that into our discussions with the JCC, who commission ambulance services on behalf of the whole country. I believe that is a pattern that we see across the whole of Wales, partly driven by the response times. So I know that has been reported in JCC meetings previously, that is a pattern across the health service across the whole country, actually, that's emerging.
Thank you, Nicola. So let's go now to Robert, please.
Thanks. A general question on InReach. Let's take the example where a consultant comes into our county and delivers a service to patients. Supposing, and I know there are many advantages of the InReach, but supposing that those patients were instead directed to the base DGH, would the waiting times be the same?
I don't think so, Robert. So because the lists are held separately, and obviously the capacity is very different, the demand of capacity is very different.
Yeah.
So I think if that patient, for example, was employed by an Iron Bevan, the waiting times would be as reported in the report for an Iron Bevan. And for ourselves, we are generally much shorter, the waiting times for patients.
So we're generally shorter than if they were referred. I just think, because if it was the case that the act of the consultant, say, coming to Powys was itself, an issue because they had, work to do back at base, which wasn't anticipated, that it might be the other way around. Oh, good. So the reassurance is that in general, it's still quicker for patients rather than us referring them to the base DGH.
At present, that's the case. Obviously, with the GIRFT review, we'll be looking to potentially change. I think we're coming to the conclusion that model of InReach, with the fragility that it gives us, may not suit us as well as we'd like for the future. So it is something we're going to need to reconsider, and we would also be looking to be enhancing quite considerably the amount of activity that we do locally, and then we need to take into that account that balance of waiting times and our own demand and capacity planning. But that's for the future. At the moment, our waiting times are shorter. Yes.
Thank you.
Thank you. You raise an important point, Robert, and I'm going to invite Elaine and Kate initially to comment, if you have anything to add, please.
Thank you, Robert. I think Nick has given a decent response there. The only thing that I was going to say that we need to keep a really close eye on is where the consultant is delivering sort of more, even more specialised care. So where there's a particular low activity service that we InReach, where maybe the consultant comes less frequently. So that's something that we keep a very close eye on, because there's a risk there that actually if somebody's only coming to us once every 3 months, that's going to have a significant impact on the amount of delay that patients have before they have that appointment. But otherwise, thank you to Nick for responding there.
Kate, our medical director, do you have anything to add?
Yeah, thank you. Just a quick comment on the differences between the provider in each provider service and the services in the DGHs. It is a little bit complex in that we need to remember the patient cohorts are different. In Powys, in our provider service, we tend to treat patients with a sort of lower acuity and so usually sort of simpler conditions, which could also tend to we're not quite comparing like with like exactly, so we just need to be cognizant of that. And in terms of the GIRT work, then that will absolutely be looking at how we can most effectively deliver the best outcomes. And so really reviewing what we're doing and looking how our system might most effectively work. So